My name is Julie Reiland. I am a breast cancer surgeon, so I take care of women with breast cancer at Avera in Sioux Falls. We were one of the first pioneers in the country to have a machine that offered women radiation at the time of their original breast cancer surgery. That's a huge piece for us. We got that because we have such a rural area and we have so many women that were traveling such long distances to have their breast cancer treatment. And we felt very strongly that if we could make their time with us shorter and more efficient, that we would have a much happier patient population and we could do a much better job for their quality of life. And so Avera partnered with me and we really pursued having an intraoperative radiation program here. That's one of the things that we do. Another thing is the oncoplastic surgery, where I, at the time of a breast cancer operation, will take out the cancer, but then give that woman a plastic surgery lift so that we can decrease the unsightliness of a breast cancer operation that oftentimes happens. And so when we combine those two, radiation at the time of surgery with a lift, we get a patient who gets sometimes a single treatment, one operation, and their breasts look beautiful, they're happy, they've had their radiation and their surgery all in one day, and they get to go on and do other treatments if they need them, or go back to their regular life. If you've just been diagnosed with breast cancer, my first piece of advice is do not panic. You have time to investigate all your options and look at where the best place for you is going to be. 90% of my patients are safe in keeping their breast tissue. That means that a lumpectomy is just as good as a mastectomy. And we know that a lumpectomy and mastectomy does not improve your survival. It's not going to make you live longer. So why not keep that breast tissue? And if we know that in a lot of women who have small tumors, who are of a certain age, that we can give radiation to the tumor bed at the time of surgery and lessen the amount of radiation you need or give you just one dose, we can help you with your treatment. We can make this a much shorter journey to the other side, to being survivor and a thriver. At Avera, we use electron IORT for treatment of our breast cancer patients because we believe that this is the future. In order to do a better job for our patients, we have to stay cutting edge and we have to look at these new innovations. When Avera chose Mobetron over the LIAC or the low voltage X-ray systems, Intrabeam and Zoft, we chose that because we felt very strongly in terms of the low voltage X-rays that the depth of penetration for that tumor bed was not going to be deep enough and that our patients would really be at risk for being undertreated and that their risk of recurrence was much higher. Mobetron and intraoperative radiation with electrons has been used for the past 40 years. So we know that the electrons are much easier to treat and to prescribe the correct dose and have a lot more control over where those electrons go in the tumor bed. What's unique about Mobetron is that I feel very much that we are using a machine that is very accurate and has had multiple tests and has gone through rigorous testing and evaluation to make sure that they're giving us a machine that we can count on and rely on each and every time that we use it. I did not want my patients coming to me in 3 to 5 years with a breast cancer recurrence and have to look at them and tell them that the device I chose wasn't good enough or didn't do the job that I wanted it to do. I feel very strongly that I had to be very careful about which device we chose here. These are really important people to me. And to have the disappointment of telling them that their breast cancer has recurred would be devastating, not just for them, but for me. When we looked at Mobetron, I felt very confident that when I compared them to the other machines that are out there in the United States, Mobetron by far was going to give me the best assurances that I would never have to have that conversation with my patients, that I would never have to tell them that they had a recurrence because we used an inferior machine. It has to be the best. And that's why we chose Mobetron. I really wanted something I could count on, that I really felt that I could look my patients in the eye and tell them, yes, this is the right device, this is the best that we have, and there isn't anybody that's going to get it better. There's a lot of hope in this disease, and I am so pleased that I have the tools to give those women hope.